Uh, Hi, everybody. So I'd like to thank the conference organizer, David Malkin in particular, for giving me the opportunity to talk today. So I've been very much inspired by the LFS researchers and families who are here at this conference for the past 2 days. The positive energy and the emotion is palpable. And I also like to thank Louis Zhang for being my collaborator and mentor for the past 4 or 5 years and being patient with me learning about Li-Fraumeni syndrome slowly. So I'm a biostatistician by training, and my life outside of LFS research is actually a cancer genomicist and developing bioinformatics tools for analyzing next generation sequencing data. But today I'll talk to you about the cancer-specific characterization in families with LFS. So let's put that story into the context. So it goes back to this first New York Times article about a woman weighing a mastectomy after testing positive for BRCA1. And here is her own hand-drawn pedigree, the family history of cancer. So this has motivated a group of researchers trying to model the inherited susceptibility in that there is a high-risk DNA variant that is carried by a founder and transmitted through the later generations. For the offsprings who carry this high-risk DNA variant, unfortunately, then they are at a higher likelihood of developing cancer in their lifetime. So we focus on 2 probabilities to assess risk that is interpretable for clinical counseling. The probability of cancer-causing inherited DNA variant given family history, and the probability of cancer diagnosis in future given family history. So there's a category, a type of risk assessment models called Mendelian models. So here I give you an example of Mendelian models. So on the top is the input of a model, which is the family history, detailed family history of cancer. The arrow, the counselee is pointed to by an arrow. She has multiple primary melanoma at age 30. And she has her paternal aunt and grandmother are also melanoma patients. So she wanted to know her probability of carrying a mutation in a susceptibility gene, given her family history. So here we compare the probability given by our model with a clinical criteria. This is an artificial example. This clinical criteria is based on the summary of family history. In this case, we simply ask whether the family has more than 2 cancer patients. So our probability is 0.43 for this for the counselee and the family history. The criteria gives a yes answer. All right, so now when we remove these cancer cases, so the aunt is now healthy at age 40, then we give a 2% probability, a much lower probability, and the criteria is changed to no. In the next scenario, so let's focus on the father. The father stayed healthy at age 76, weakened the evidence that he actually carried a mutation and transmitted to his daughter. So if we swap the disease outcome between the father and the aunt, and now the father has a melanoma and the aunt is healthy, so our probability is increased by 2 times, so 0.82, versus the clinical criteria stayed as yes, and due to its binary outcome, the nature of the binary outcome. So in summary, the Mendelian models provide risk assessment in the final resolution and respond to detailed family history information. So Mendelian models have been successfully employed to breast and ovarian cancer, to colorectal cancer, pancreatic, and cancer and melanoma. And all functionalities are available in our package called Bayes Mendel, and also a popular clinical software called CancerGene. So now we have developed LFS Pro for risk prediction for Li-Fraumeni syndrome, and it's already available from Bayes Mendel and CancerGene. So here again, the input of our software is for all family members, their relationship to the counselee, their cancer status, and their age of onset or age at last contact if unaffected. Our output is probability of the counselee carrying a mutation in P53 and the probability of the counselee developing cancer in future. So we tested LFS Pro in 3 study populations: the MD Anderson Pediatric Sarcoma Cohort, International Sarcoma Kinship Study, and NCI LFS Study. So a total of 800 families, 22,000 individuals, and more than 1,300 of them were tested for P53. So here we use a figure called ROC curve, which compares the probability estimates with the test results. So the y-axis is the true positive rate, which is sensitivity, and x-axis is the false positive rate, which is 1 minus specificity. So a curve that is closer to the upper left corner corresponds to better model performances, and the area under the curve that being close to 1 also indicates good performance. So we see that LFS Pro shows good performance in all 3 data sets, in particular the MD Anderson and NCI data set. We also see that the Champray 2015 criteria sits right on the curve in 2 of the data sets, which is reassuring to us. So providing the probability using LFS Pro gives us additional leisure of changing our cutoff in sacrificing a little bit of specificity in order to gain on the sensitivity. And so running both Champray and LFS Pro in the clinic across many data sets will help us refine the cutoff for LFS Pro. Oops, sorry. Okay, so now I switch gear to the penetrance estimation using MD Anderson data. So penetrance is an important parameter in LFS Pro, and by itself an important information for study the susceptibility or genotype-phenotype relationship for mutations. It is defined as the probability of primary cancer onset by a certain age, given the susceptibility gene mutation status. So here, my former postdoc, Song Junshin, estimated the penetrances for specific cancer types in LFS. Breast, sarcoma, and all other cancers combined. The curves here shows the probability of a specific type of cancer prior to having others. So as we see, the curves for the breast sarcoma and all other cancers combined are very different. So here, the onset of one cancer excludes the onset of all others. So these events are not independent. And the dependence needs to be modeled using a survival analysis strategy called competing risk. So as it turns out, the current literature in survival analysis cannot be used directly to estimate penetrance as we needed. So we were actually very excited about this, and we were able to develop a very novel statistical approach for the penetrance estimation. And our statistical methods were submitted to the JAMA equivalent journal in statistics called JASA, and the editor really liked it. The difference in the statistical journal is our paper was reviewed for 5 months and given 1 year to revise. So welcome to the world of statisticians. They really want every single detail to be addressed. Yeah. So here's the interesting biology observation. Here we compared the breast cancer penetrance for TP53 versus BRCA genes. And as we zoom into the first 25 years, we see that the majority of the breast cancer onset seem to be due to the TP53 mutations. And last, I showed the estimation of penetrances for the number of primary cancers in LFS. Here we modeled the single primaries versus the multiple primaries, which is 2 or more cancers. Just quickly, I hope you see the focus on the 2 thicker lines. The lower curve is for a healthy individual probability of developing the first cancer, and the upper curve is for a cancer patient already diagnosed at age 20, his probability of developing the next cancer. And then also novel statistical methods. And this is done by Jialu Li, my student. Here we validated the both type of risk and then got really nice results. I was amazed how well it worked in predicting the cancer outcomes. Now I'll end with another clinical example here, a made-up pedigree where the child has mutation in p53 affected at age 7, current age 14, and LFS Pro predicted his probability of developing the next cancer in 5, 10, and 20 years. So summary, we have developed LFS Pro, and novel statistical approaches are needed. Statistical models can only go as far as the data goes, and we have the MySQL database, so please send us your data. And thank you.